Hello, this is another video of output-based learning using this classification by mind maps for this subject that I believe needs a good classification. And I'm again using the question-based format for learning. Again, this is for personal learning. And if you have any suggestions, please feel free to let me know. I believe that I should share this because it looks like a good classification, and I don't remember anywhere else I could have this classification. This subject needs some clarity. So, hypersensitivity reactions and transfusion reactions, I tried to kind of simplify them and categorize them into its understanding into the humoral element, cell-mediated element, hallmarks of pathophysiology and clinical manifestations, as well as examples. So, first things first, what is the humoral and what is cell-mediated immunity elements of type 1, 2, 3, 4 hypersensitivity reactions? First point is type 4 hypersensitivity reaction does not have humoral element. All the other types have humoral and cellular element. In other words, type 4 only has cellular element. Now, what is the humoral and CMI elements of type 1? The humoral element is IgE, and cellular element is mast cells and basophils. True or false? Eosinophils play an important role in type 1 hypersensitivity reaction. That is false. Mast cells and basophils are the cell elements of type 1. What is the pathophysiology of type 1 hypersensitivity reaction that we need to bear in mind? We should remember that it includes an immediate phase and a delayed phase. Don't confuse the delayed phase with the delayed type hypersensitivity reaction or type 4 hypersensitivity reaction. So, what is the basis of each phase? The immediate phase is mediated by pre-sensitized mast cells and pre-formed antibodies. The same story that you know is cross-linking of IgEs on the surface of mast cells by the antigen. That would trigger release of components of the mast cells and basophils, especially the substances that are vasoactive, and their target is postcapillary venule. This is the immediate phase. What is the story of the delayed phase of type 1 hypersensitivity reaction? The other elements, such as cytokines released from mast cells and basophils, would result in inflammation. That is the story of the delayed phase. What are the examples? Allergic reactions and anaphylaxis. While we said IgE is involved in type 1 hypersensitivity reaction, what are the humoral elements of type 2 hypersensitivity reaction? When it comes to type 2, think of IgG, IgM, and complement as the humoral element. Also, whenever you hear the term autoantibodies, that is when we are talking about type 2 hypersensitivity reaction. Autoimmunity could be seen in any kind of hypersensitivity reaction, but autoantibodies is the hallmark of type 2 hypersensitivity reaction. What is the cell-mediated element of type 2? Almost all kind of white species, but specifically natural killer cells and macrophages and eosinophils, but also neutrophils, play an important role in type 2 hypersensitivity reaction. Pay attention to the fact that among the cells, natural killer cells specifically are relevant for type 2 hypersensitivity reaction. So let us finish the story of cell-mediated component. What are the important elements of cell-mediated immunity in type 3 and 4 hypersensitivity reaction? Remember, in type 3 hypersensitivity reaction, the most important element of the CMI is neutrophils. In type 4 hypersensitivity reaction, T cells. Any kind of T cell, but specifically we would talk about cytotoxic T cells and macrophages, plus T helper 1 cells and T helper 17 cells. So if you hear T cell, it means type 4 hypersensitivity reaction. If you hear macrophage, it could be type 2 or it could be type 4. If you hear neutrophil, that's the hallmark of type 3, but also plays minor role or some role in type 2 hypersensitivity reaction. If you hear eosinophils, most relevant is type 2 hypersensitivity reaction, the same way that if you hear mast cell and basophil, that's the hallmark of cell-mediated component of type 1 hypersensitivity reaction. And again, what are the humoral elements of type 3 hypersensitivity reaction? The humoral elements are immune complex and complement. So in what types of hypersensitivity reaction complement plays a role? It could play a role in almost all types except for type 1, but most significant role of complement is for type 2 and type 3 hypersensitivity reaction. Immune complex is type 3, autoantibodies is type 2. Okay. Now that we have compared and contrasted the humoral versus cell-mediated immunity elements of these four types, I want to go on and compare and contrast the pathophysiology of these types. We discussed the type 1 pathophysiology would be cross-linking of the IgE by the external antigen on the surface of mast cells and basophils, and immediate and delayed reactions. What is the pathophysiology of type 2 hypersensitivity reaction? Type 2 hypersensitivity reaction has a very beautiful three element of its pathophysiology, or three possible pathways of its pathophysiology. All three elements are antibody or autoantibody mediated. So autoantibody mediated cellular destruction, autoantibody mediated inflammation, and autoantibody mediated receptor mediated cellular dysfunction. These are three arms of pathogenesis of type 2 hypersensitivity reaction. Define cellular destruction as the pathogenesis of type 2 hypersensitivity reaction. The first event in cellular destruction in type 2 hypersensitivity reaction is opsonization. Always remember this fact. And then, what are the possibilities after opsonization? After a cell is opsonized, three possibilities would follow. It would either undergo phagocytosis by macrophages, or it would result in activation of complement cascade, or it will result in cellular destruction by natural killer cells. What is ADCC? Specifically, when opsonized cells are killed by natural killer cells, that is called antibody-dependent cell-mediated cytotoxicity, or ADCC. This is probably a good place to ask for what are the examples of cellular destruction in type 2 hypersensitivity pathway. Every time you hear a thrombocytopenic hypersensitivity or hemolytic hypersensitivity, think of cellular destruction of type 2 hypersensitivity reaction, meaning think of the three possible pathogenic pathways of cellular destruction we talked about. So, conditions such as transfusion reaction, the hemolytic transfusion reaction, or hemolytic disease of newborn, or immune hemolytic anemias, or immune thrombocytopenic purpura, also known as idiopathic thrombocytopenic purpura. The immune-mediated thrombocytopenias and hemolytic reactions or hemolysis all are due to cellular destruction mediated by one of the three possibilities of cellular destruction in type 2 hypersensitivity reaction. Now, what are the examples of inflammatory conditions and what's pathogenesis in type 2 hypersensitivity reaction mediating inflammation? Three very important examples to commit to memory, partly because it kind of sounds far-fetched. Always remember that when we talk about inflammation, we mean complement-mediated inflammation activation. Remember that coagulation, complement, and inflammation cascades are intertwined with each other. The examples are good pasture, hyperacute transfusion, hyperacute transplant rejection, as well as acute rheumatic fever or streptococcal mediated myocarditis as an autoimmune reaction, not as direct infection. And final example is when antibodies against a specific tissue receptor or molecule would result in cellular or histologic dysfunction. What are the examples? Again, we are talking still about type 2 hypersensitivity reaction, and the examples include Graves' disease and myasthenia gravis, but also pemphigus of the vulgaris type, pemphigus vulgaris, and non-insulin dependent or insulin resistant diabetes mellitus, as well as pernicious anemia. In all these, you can imagine an antibody is produced against a receptor or a cellular element that would result in cellular dysfunction. For example, in pemphigus vulgaris, what is the target of the antibodies? The target of autoantibodies are desmoglein and also activation of the proteolytic enzymes that follows this process that would result in impaired intercellular adhesions. Or in pernicious anemia, there are antibodies against intrinsic factor. Do you remember what was the target of autoantibody in ITP? Yes, in idiopathic immune thrombocytopenic purpura, the antibodies are formed against glycoprotein 2b3a. Okay, enough said about type 2 hypersensitivity reaction. We discussed the cell-mediated and humoral elements of type 3 hypersensitivity reaction, but what is its pathogenesis? Type 3 hypersensitivity reaction has a very beautiful and precise, stepwise action that we need to exactly commit to understanding and memory. That is, the first event is formation of immune complex, most importantly involving immunoglobulin G, IgG. This would result in complement activation. Complement activation would result in neutrophil recruitment, especially via C5a, the chemotaxic factor, and then neutrophils would release their lysosomal enzymes to cause cell destruction. What are the examples of type 3 hypersensitivity reaction? SLE, rheumatoid arthritis, serum sickness, Arthus reaction, and polyarthritis nodosa, and other vasculitis syndromes. And finally, what is the pathogenesis of type 4 hypersensitivity reaction? Type 4 hypersensitivity reaction can have two arms in pathogenesis. One is direct cytotoxicity mediated by cytotoxic T cells, and the other arm is T helper 1 mediated or T helper 17 mediated inflammatory reaction. So, very important question, and from now on we enter the higher level understanding of this hypersensitivity reaction. We mentioned that type 2 hypersensitivity reaction involves cytotoxicity, and now we are saying that one of the two possible pathways of type 4 delayed type hypersensitivity reaction is also cytotoxicity. So how do we differ these two types? If you are given a case or a vignette in which hypersensitivity reaction seems to be mediated by cytotoxicity, how are you going to figure out if it is type 4 or if it is type 2, considering the fact that we cannot necessarily depend on the timing because there is huge overlap in the timing of these reactions? Well, if you are only going to answer those questions based on pathogenesis, we should remember that the cytotoxicity in type 2 hypersensitivity reaction is antibody-dependent cell-mediated cytotoxicity, and it is achieved by natural killer cells. However, cytotoxicity in delayed type or type 4 hypersensitivity reaction is mediated directly, which means without a need for antibody, and it is performed by cytotoxic CD8 plus T cells. Now, the same question, we mentioned type 2 hypersensitivity reaction also can have an inflammatory pathogenesis, and now we are saying that type 4 hypersensitivity reaction can also has an inflammatory pathway of its pathogenesis. So how do we distinguish these two? Remember, the activation of inflammatory cascade in type 2 hypersensitivity reaction is mediated by antibody activating the complement cascade. That type 2 hypersensitivity mediated inflammation is referred to as FC segment mediated inflammation. However, in hypersensitivity reaction of the cell mediated or type 4 hypersensitivity reaction, the inflammation is totally cellular. It means T helper 1 and T helper 17 cells would recruit and produce cytokines that would activate and recruit macrophages. What are the examples of conditions with type 4 delayed type hypersensitivity reaction? You can remember that by 5T, TB, which means transdermal TB test and other transdermal patch tests. You can think of it as tuberculin test. The other example is transplant rejection of graft versus host, because hyperacute transplant rejection is, for example, type 2 hypersensitivity reaction. And then we have dermatitis, touching or contact dermatitis, and type 1 diabetes. Remember we mentioned that non-insulin dependent diabetes mellitus or type 2 diabetes is antibody mediated, while type 1 diabetes is associated with destruction of the Langerhans beta islet cells, and therefore it is a type 4 hypersensitivity reaction. On top of that, remember thyroiditis, such as Hashimoto thyroiditis, and don't confuse it with myasthenia gravis, or with Graves' disease, which is type 2 hypersensitivity reaction. Thyroiditis is Hashimoto, is type 4 hypersensitivity reaction. Then if you remember these 5 T's, then add to that multiple sclerosis, add to that IBDs, add to that SS, which stands for both systemic sclerosis and Sjogren's syndrome, are type 4 hypersensitivity reaction. And at the end, remember rheumatoid arthritis is both type 3 and type 4 hypersensitivity reaction. Now, if we want to kind of simplify the clinical picture of these 4 types of hypersensitivity reactions, what can we do? We remember that type 1 is allergic reaction. Any kind of allergic reaction to food, to drugs, that is defined as allergic or anaphylactic reaction, is type 1 hypersensitivity reaction. Type 2 hypersensitivity reaction could be simplified as thinking of the conditions in which we have autoantibodies, specifically autoantibodies or antibodies to specific tissue. You think of hemolytic conditions, you think of thrombocytopenias, you think of conditions such as good pasture or acute rheumatic fever, that we have autoantibodies against cardiac myocytes. You think of myasthenia gravis, pemphigus vulgaris, Graves' disease, and non-insulin dependent diabetes mellitus. In all of these examples, we have and pernicious anemia. In all of these examples, we have antibody specific to one specific tissue, either platelets or RBCs or thyroid tissue, etc., etc. How we think of type 3 hypersensitivity reaction clinically? Any condition that has systemic involvement, specifically arthritis conditions such as we mentioned, SLE, rheumatoid arthritis, reactive arthritis. Specifically think of the vasculitis syndromes, PON, but also SLE. But also remember that serum sickness itself is a small vessel vasculitis, and similar to PON, is associated with fibrinoid necrosis. And then also remember that serum sickness is mainly nowadays not associated with serum, but mainly associated with certain drugs. For example, non-protein antibiotics such as beta-lactams and sulfa drugs, sulfa antibiotics, as well as monoclonal antibodies are the most famous examples of conditions that could be associated with serum sickness. And then the arthritis reaction, even though it is localized, the only localized example of type 3 hypersensitivity reaction is the arthritis reaction due to subdermal injection of an allergen. And type 4 hypersensitivity reaction, I just remember 5 T's: multiple sclerosis, IBD, SS, systemic sclerosis, and Sjogren's syndrome. The 5 T's were TB and transdermal patch test, thyroiditis, touching or contact dermatitis, and graft versus host type transplant rejection. I needed to add once more that hyperacute transplant rejection is type 2 hypersensitivity reaction. Again, once more, conditions that are glomerulonephritis, vasculitis, or arthritis belong to type 3 hypersensitivity reaction. This kind of simplifies in some ways, hopefully, or at least categorize and help us distinguish different types of hypersensitivity reactions. Hypersensitivity reactions should always be understood or studied in parallel to transfusion reactions and transplant rejection or transplant reactions. So for now, I want to talk about transfusion reaction because transplant rejection is a little bit longer and probably requires a separate recording, but it is a little bit more straightforward. I have myself categorized the transfusion reactions, the blood transfusion reactions, into 3 categories. And this could be counterproductive for some, but it helps me a lot. The ones that are associated with type 1 hypersensitivity reaction, transfusion reaction, don't confuse with transplant rejection, it's transfusion reactions, type 2 hypersensitivity reactions, and TRALI. I would begin with TRALI. TRALI is just transfusion-related acute lung injury. The very interesting point about TRALI is if you asked what transfusion reaction has similar pathogenesis to that of graft versus host, that is TRALI. Why is it so? Because in TRALI, or transfusion-related acute lung injury, the donor's antibodies, especially anti-MHC class 2 and anti-leukocyte antibodies, react against the recipient's neutrophils and, in other words, white species and pulmonary endothelial cells. What is the clinical manifestations of TRALI, or transfusion-related acute lung injury? Most important manifestation is a patient who develops hypoxia within 6 hours of a transfusion reaction and is in respiratory distress. Considering the fact that respiratory distress could be seen in other types of transfusion reaction, how can we distinguish this TRALI from, for example, anaphylactic or other types of hypersensitivity reactions or transfusion reactions? You order chest X-ray and you see there are evidence for non-cardiogenic pulmonary edema, which means a patient who is in hypoxia within 6 hours of transfusion now has diffuse interstitial markings in his chest X-ray as an indication of non-cardiogenic pulmonary edema. That is definition of TRALI. Now we can focus on transfusion reactions that are due to type 1 or type 2 hypersensitivity reaction. Well, transfusion reaction that's type 1 hypersensitivity reaction is either allergic or anaphylactic. What is the difference? The difference is just the severity of symptoms. If the patient only has urticaria and pruritus and maybe mild fever within minutes or a couple hours of transfusion, that's just referred to as urticarial or allergic transfusion reaction. However, if the patient has symptoms of anaphylaxis, that's called anaphylactic type 1 hypersensitivity reaction type transfusion reaction. By the way, what were the hallmarks of clinical manifestations of anaphylaxis? Well, the patient will be in shock, the patient would have bronchospasm and therefore will have wheezing. Could have also respiratory arrest. So, how do we manage these 2 types? Well, for the allergic urticarial type, we can just give the patient antihistamines. But for the anaphylactic type, we need to give the patient some epinephrine, and if needed in severe cases, also glucocorticoids. So that's type 1 hypersensitivity reaction that causes transfusion reaction. Now is our major focus in transfusion reaction, and that is transfusion reactions that are due to type 2 hypersensitivity reaction or antibody mediated. I have categorized them into the categories of hemolytic and non-hemolytic transfusion reactions of type 2 HSR. The hemolytic transfusion reactions could be acute or chronic. So here's the question. Allergic or anaphylactic transfusion reaction as well as hemolytic transfusion reactions are both due to antibodies against the transfused component. What's the difference? Well, when we have allergic or anaphylactic transfusion reaction, the antibodies are performed against the plasma proteins of the donor blood. And the most famous example is antibodies against IgA, for example, in a patient who is IgA deficient and receives IgA containing blood product. But in type 2 hemolytic type transfusion reaction, the antibodies are against RBCs, especially against ABO or other blood groups on the surface of RBCs. that would result in hemolysis. Which brings us to the next question. What's the difference in the clinical scenario? Well, while we mentioned type 1 hypersensitivity reaction mediated transfusion reaction manifests itself with either allergic urticarial reactions or anaphylaxis, type 2 hypersensitivity reaction mediating transfusion reaction of hemolytic type would show evidence of hemolysis. Now, what are the evidence of hemolysis? Most importantly, hemoglobinuria and hemoglobinemia, but also chest and flank pain. Remember, patient could have respiratory distress, patient could have dropped blood pressure, but especially in the hemolytic types, we could have the flank and chest pain, and most importantly, the hallmarks of intravascular hemolysis being hemoglobinuria, hemoglobinemia, and extravascular hemolysis being jaundice, or any kind of hemolysis actually manifest as jaundice. So these are the hallmarks of the type 2 hemolytic hypersensitivity reaction. Then the question is, how do we distinguish between the acute versus chronic forms of hemolytic transfusion reaction? By definition, the acute form is the one in which preformed antibodies are already present in the blood. For example, in ABO mismatch, we already have IgM against the donor's blood group. But in the chronic hemolytic transfusion reaction, the patient is pre-sensitized, but there is no preformed antibodies yet in his or her blood. It's something similar to the Rh incompatibility of the Rh negative mother and Rh positive fetus, in which it doesn't show it in the first delivery, first pregnancy. It's just mother gets sensitized. So same is true about the chronic type hemolytic transfusion reaction as opposed to the acute hemolytic transfusion reaction. And finally, we have the febrile non-hemolytic transfusion reaction. What is its pathogenesis or pathophysiology? Remember trolley, in which the donor's anti-HLA and anti-leukocyte antibodies react against the recipient elements? Here it is the opposite. Here is the normal version. The recipient has anti-MHC and anti-leukocyte antibodies against the donor's leukocyte and HLA proteins. A second pathogenesis for febrile non-hemolytic transfusion reaction has been said to be the cytokines that are produced or formed during the storage of blood products. And finally, this febrile non-hemolytic transfusion reaction is the most common type, is clinically insignificant up to a point that it doesn't require any treatment, and its manifestation is usually fever and chills and rigor. Well, this hopefully would kind of clarify, as it's clarified for me, this categorization, the different types of hypersensitivity reaction based on the categories of humoral versus cell-mediated elements, the pathophysiological hallmarks, comparing and contrasting them with each other, and their examples, the same way that transfusion reactions could be understood. Couple final points, and that is, if you are suspicious of hemolysis, what tests do you order? Tests of hemolysis including checking the levels of haptoglobin, lactate dehydrogenase, and indirect bilirubin, as well as direct Coombs or antiglobulin test. For example, in the acute hemolytic transfusion reaction, direct Coombs would be positive within hours of transfusion in a patient who has, for example, tachycardia, tachypnea, and flank or chest pain, especially with hemoglobinuria, hemoglobinemia. But in chronic type hemolytic transfusion reaction, direct Coombs test would be positive within 1 to 2 weeks. Okay, that is one of the major differences. And the very final question of transfusion reactions mentioned two groups of people who are prone to transfusion reaction regardless of the type. Multiparous women women who have given birth to several babies, as well as people who have received several times have received blood products. These are the two groups of people who have much higher risk of transfusion reaction compared to normal population, compared to other people. Okay, thank you very much. Again, this by no means was to be educational for anyone else. Otherwise, I needed to be much more efficient than this, but I believe this categorization could help clarifying this subject. For some reason, this subject has been a little bit vague, and at least for my understanding. And I tried to make it clear for myself through this mind map, fishbone categorization, and in output-based learning and questioning. I hope you enjoyed it. Please feel free to provide any feedback if you like, and appreciate your attention to this. Have a great